Okay, now let me take you away from the children's side. Forget the children part of this, okay? Okay, Jamie?
Isn't it his problem that he knows what's in the best interest of his patient, and he's going to impose that remedy on the patient regardless of whether the patient wants it or not? He's already taken away making the decision for the patient. In this case, it's less complicated because it's a child, but what if it were an adult that were somehow resisting what was in the patient's best interest? Then it gets more complicated. What if
It's real
a Jehovah's
complicated.
Witness who needs a blood transfusion?
That's kind of the way I saw the story too, was that it's kind of an example of the paternalistic role of the physician, in that I know what's best for you, and damn it, just let me do it. And you know, if you can forget it as a child, then you can really extend it to paternalistic.
Those are all good points, but I'm going to focus you back on the. I don't have any disagreements with any of those points. That's why the story is so rich. Let's focus on the. All right.
Let me admit this story is all too familiar to me, and notice that we're discussing it, and notice that it got written. What I mean by that is that the person who wrote this is not proud of this. He's writing it basically not as much for us as for him. We're reading it for ourselves because it has poignancy, but the relationship ultimately, I'm coming to understand that at sort of more basic levels for myself, is the relationship between two people. One of them happens to be sick, and the other happens to hold him or herself out as a healer. But ultimately, you're sitting looking at the eyes of another person. And part of the character, I think, of the profession is a willingness to become involved. You know, as one of the articles that Karen gave us, I think, pointed out, one doesn't protect oneself by being distanced. One becomes involved and hopefully sees through a task and then draws energy from it, I guess. But the willingness to be involved and be vulnerable, even to the extent of becoming angry and ashamed of oneself, is part of our commitment. It'd be easy to simply read about it or watch it on TV or not think about it at all, but he's there. And there is, I agree with what was said, there is definitely other ways of handling this. And if you can bring your most centered self, rested, and with a good perspective to the bedside, absolutely there's a more skillful way of handling this. But that's not what he was talking about, and you know, and I think this is all very, very real, and not to be condemned. I think for myself, to be seen as a mistake that's good grist for the mill.
I'm going to call for discussion on this case now because we have to move on. I'll make two closing comments. They're all very interesting comments. First, if you have it, I would invite you to read the case I called Do It My Way in the handout, which was a case of my own about 14 years ago. The first one in my hand. It's called Do It My Way. I'm not inviting you to read it now, but you might read it after you go home, which has many similarities to this case. The case that I got involved with a gentleman that I was trying to give informed consent for a procedure. Now we sort of got involved in a power struggle that I didn't understand until a lot later. So I would invite you to read that, reflect on it. Secondly, for your later reflection, I'll invite you to read this poem entitled Getting to Sleep in New Jersey, which was written by another John Stone. It was a John Stone who is a poet and a physician, which is a tribute to Dr. Williams. And I'll just invite you to read that later on. It's a very nice tribute. And I'm going to go ahead now and the other comment I would make would be, you might reflect on the fact that would, in fact, as Sue pointed out, how much would patience and perseverance help prevent, particularly if we cultivate it, and help prevent these struggles, because we get caught in these things. And and it's important to develop skills to prevent these circumstances from happening. But sometimes they do happen. And then when they do happen, what do we reach for? And I think what we reach for are some fundamental character traits that we have. And so then the question, and they happen repetitively in lots of professional work and, of course, of other walks of life. So then my question would be then, what kind of things do we try to cultivate in ourselves so that what the kind of knee-jerk responses we get in those moments, how do we develop them? How do we develop the patience and the perseverance to sort of help us through, as opposed to the kind of being taken over by anger, which most of us in most circumstances would wish that we had not. There are certainly a few circumstances where it's useful, but mostly we not, at least in the world in which we ordinarily live. I want you to move on to the poem entitled B, or the name of it is Doctors, has a B on it, and I would ask you to read it silently to yourself, and then I'm going to read it out loud, and then we'll discuss it. Everybody got it? It's called Doctors, with two stanzas. Okay, I'm going to read it out loud, and then I want to ask you to think about what this means. Doctors. They work with herbs and penicillin. They work with gentleness and the scalpel. They dig out the cancer, close an incision, and say a prayer to the poverty of the skin. They are not gods, though they would like to be. They are only a human trying to fix up a human. Many humans die. They die like the tender palpitating berries in November, but all along the doctors remember, first do no harm. They would kiss it if it would heal, it would not heal. If the doctors cure, then the sun sees it. If the doctors kill, then the earth hides it. The doctors should fear arrogance more than cardiac arrest. If they are too proud, and some are, then they leave home on horseback, but God returns them on foot. I said at the beginning we were first going to talk about the general issue of importance of characteristics, which I tried to bring out in the discussion of the use of force. And now I want us to focus a little bit about what actual characteristics are helpful. In this case, certainly for doctors. So basically, I'm asking you to analyze this poem a little bit in regard to that question. Yes, ma'am.
Looking at the end about arrogance, I guess I really looked at that in the doctor, and I looked at all of those things. So I remember a conversation I had one day with somebody who was saying that doctors have an unusually high rate of, they're private pilots of accidents compared to the general population. And surgeons are worse of all. And the feeling was that it is an arrogance. I don't need to follow the chart or whatever. I'll be all right. And this person said, but God knows I want a surgeon like that. I don't want one who picks up the scalpel and says, should I cut or shouldn't I cut? In other words, that the arrogance is also maybe side by side with the adventurous sometimes, the surgeon who's willing to take the risk that may kill but may open a whole new avenue. I'm playing the devil's advocate a little bit here because I guess that's not the kind of doctor I want personally, but I've heard that other side said.
Okay, so what you're saying is that the poem says that arrogance is not good, but you can make an argument that arrogance is good per physician. Other comments about that? It's a very interesting point. Any counter arguments?
think the problem's asking us that doctors put themselves on the patient's level. It's the extent where the patient's coming from. They tend to always dictate, take technical things for granted. Patients become quite confused by that. Don't want to render proper treatment.
So you're saying that unless doctors get on the same level as patients, I mean, the poem is saying that they can't communicate well with their patients and they can't really sort of identify with them?
Right.
In the first verse of this, it says, but all along the doctors remember first do no harm. I think that relates to what you said earlier, in that, all kinds of things happen, but you need to have the base, the basic values, the things that are valuable to you, that you measure things against. And without those, you do tend to be arrogant and make decisions that aren't good or just surrender to impulses. But if you always have these basic values that you judge your every action against first, you'll come out well, like first juvenile.
Well, now then, are you saying that the way to avoid, I'm playing a little bit of the devil's advocate here again, are you saying that the way to avoid arrogance is to not be arrogant?
No, I'm not particularly speaking of arrogance, but I think what we're talking about a lot about is behavior and decision making and how things are done and how you approach patients. And if you have consciously thought out what is important and what the values are you want to convey and practice and be known for, that's a real conscious thing to do. And you're less likely to do things that aren't consistent with that. But when your values aren't well defined to yourself, you can't have to follow.
I think that's a very important point. There's a medical ethicist named Samuel Gorovitz who wrote this book called Doctor's Dilemmas. And one of the points that he makes in there is that in the development of characteristics of a professional, qualities like virtues, other kinds of ingrained values and other things, that the most effective way to do that is to consciously reflect on the theoretical side, what you would hope to be, and then to practice it. And then to reflect on what you actually accomplished in practice and compare that with what your theoretical objective was, and that we ought to try to train ourselves to make this movement back and forth. And that's how we can best become the kind of people that we would like to be. But is arrogance a big problem, just to switch back to that issue, for physicians? Maybe it isn't a problem for physicians. Is it a problem for the practice of physicians? I know you all have opinions about this.
I don't know if I would necessarily describe it as arrogance, but I have come to learn in my interactions with physicians is that they're very scientific based, and I wouldn't like to call it recipe, but they tend to deal and they put a lot of store and emphasis on that theoretical background. And I think it oftentimes very strongly relates to where they've been in school and to what they have learned. And they learn, and I think it's probably less of an emphasis now with emphasis on geriatrics and aging and prolonged life and more humanism. But it would seem to me that when they say in here that they're only a human, trying to fix up a human, that what I have observed is when that doesn't work, when the science and the technology falls apart and that doesn't work, they're left with not a lot to grasp onto, because then it's, now what do I do? It didn't work, and then the part that's missing is the how to be the humanist and to accept the failure of that the science didn't work. Not that the individual is at fault, but the science wasn't there or didn't happen.
Those are good comments, and we're going to stop this because I want to move on to the next thing. I'll make two closing points. Gene Emery and I were talking before this discussion about the movie The Doctor. And those of you that haven't seen it, it's out in video now with William Hurt. I think that movie does an excellent job in bringing out the issues of arrogance in physicians and what kind of implications it has for patients, and at least one way that it might be achieved for how that arrogance perhaps could be prevented in physicians. In this case, this doctor was sort of cured of it. There's a fellow named there's a fellow named Jay Katz, who's a psychiatrist, lawyer type at Yale, who's written a book called The Silent World of Doctor and Patient. Silent World of Doctor and Patient. And one of his points is that physicians will never do a much better job communicating with patients in work until they get a better handle on their unconscious motivations. And one of his points is that one of the major things that happen in doctoring is having to deal with uncertainty, which is what you're talking about. And a retreat from uncertainty is often a retreat into omniscience or omnipotence, or just in ordinary terms, doing something. And one way that folks retreat from their own inner inadequacies is into arrogance. And so it's a protective shield. And of course, it's a very destructive one. And I think if one worked on the virtues of humility, particularly, it's hard to be arrogant if you can cultivate that. Now we're going to finish up by saying a few minutes on the death of Ivan Illich. And here I want to focus a little bit on the form and content issues. And I've read this story several times in the last few years. And every time I visit it, I get something else out of it. So if you did happen to get it for this section, I would invite you to read it every year or two for the next 10 years. I think it's very profitable. Now, you don't have the first page, but I want to read you something from the first page, because I think it sets up the whole thing. First couple of lines read, during an interval in the Melvinsky trial in the large building of the law courts, the members and public prosecutor met in so-and-so's private room. And they talk about their conversations. Gentlemen, he said, Ivan Illich has died. You don't say so. Here, read it yourself. And he hands him this paper. Now, here's a description of what was in the paper. Surrounded by a black border were the words, Praskovya Fedorovna Golovina, with profound sorrow, informs relatives and friends of the demise of her beloved husband, Ivan Illich Golovin, member of the Court of Justice, and so forth. Funeral will take place, so forth. I'm so fascinated by the opening page in this short story, short novel, because one of the things, to me at least, that the novel is about is the contrast between form and content, or form and function. And one of the things that Ivan Illich did was that he learned to develop the correct form of life. And along the way, he sort of lost all the human content and didn't get much of it back until about the time he died. And here we have, and this novel, at least in part, is an examination of that. And on the first page here, we have this very formal funeral notice, which is outlined in black. Very specific form. And we have these expressions of sorrow from the spouse, and it's real clear that she didn't have any at all by the time that he died. And their relationship was at the least loveless. And his death and his suffering was a major inconvenience to her. But yet she goes through the form also. And I think in many ways, physicians in the last several decades, and this is, of course, is a hypothesis, but despite all the medical advances, which has been great, that in many ways we've been caught up in the form of doctrine as a delivery of science and have lost sight of a lot of the content issues and of course, most important, what's involved in getting in touch with patients as people. And so I wanted to bring out a couple of things from this. So it talks, we have a section on pages 106 and 107, and then 108 to 109, which we have, and I'll just briefly mention these because we're running out of time. But basically it talks about how Illich earlier talked in the novel about how he sort of had a good time as a young person, but gradually he sort of gets into lawyering and talked about how he comports himself. Second paragraph on 106, in official matters, despite his youth and taste for frivolous gaiety, he was exceedingly reserved, punctilious, and even severe. But even in society, he was often amusing and witty, etc. So we've got this sort of really gruesome sort of cloak that's settling over this gentleman in his public demeanor. And over 107, it talks about being capable of separating his official duties from his private life. And I recall about 10 or 12 years ago, in some medical throwaway, that talked about how to run your office better. There was an article in there by some guy who went around telling doctors how they ought to set up their offices and how to have a professional office. And one of the big points that he made in this article was that he had all these doctors get rid of the personal stuff like pictures of family and children and mementos and stuff, because that really interfered with the professional effort. And, gosh, maybe he got that right on this story. I don't know. I think that's pretty interesting. On page 108, upper left, he took up an attitude of rather dignified aloofness toward the provincial authorities, but picked out the best circle of legal gentlemen and wealthy gentry living in the town, and assumed a tone of slight dissatisfaction with the government and of moderate liberalism and of enlightened citizenship. So that's the background. Then it talks about him getting this progressive pain in his side after he was stretching up on something to put in a light bulb or some such thing. And he finally gets to the point where he's feeling bad and decides to see the doctor. On page 121, where I had the line written down the right side, he talks about, and he went. Everything took place as he had expected, as it always does. There was the usual waiting and the important air assumed by the doctor with which he was so familiar, resembling that which he himself had assumed in court, and the sounding and the listening and so forth, and the questions with foregone conclusions and so forth, which were evidently unnecessary, with the implication that if only you would put yourself in our hands, we will arrange everything. We know indubitably how it has to be done, always in the same way for everybody, so forth, just like it was in the law courts. So Ivan Illich, down to the underline, says, only one question, this is in the last paragraph, was important. Was his case serious or not? But the doctor ignored that inappropriate question. Well, I'm going to just stop there and ask for comments because I'm about out of time for my section. Anybody have an experience like this? And I'll move on to page 135. And basically what's happened there is Illich's illness, which is generally assumed to be a progressive cancer, has progressed. He has more and more pain. He sleeps less and less. He's more and more ill. And finally, he only gets some comfort through this peasant, Garrison. And not only is Garrison not embarrassed by his problems with his excretions, but he's willing to hold his legs up for hours, which is about the only thing that can give him comfort. And of course, symbolically, it's the only really kind of human contact he has with anybody at that stage in his life, except a little bit with his son, who sort of flutters around the periphery of this. But they don't really have a relationship anymore that can be maintained. I see this story as having striking modern parallels for reasons we all already alluded to. I think physicians have gotten very good at the form of scientific medicine and pretty good at that content. Although there was an article in the New York Times last Sunday about physicians not staying up to the newest advances or not applying them and all that. You know, for the most part, physicians have gotten pretty good, and I think most physicians really care and want to do a good job. But the form of care in which we've sort of been brought up in has too much attention to the form and not enough attention to the content of what it means to take care of people.
I'm kind of curious how you go about teaching compassion and care. How you go about. It seems to me that one of the critical issues in the death of Ivan Illich was that he went into law, but it was out of no sense of justice or injustice. It was because he felt it would afford him a comfortable lifestyle. And he was always sort of, when he was planning his career, was always sort of had that in mind. And the last thing that he had in mind would be any of these personal character virtues that you're talking about. And it seems to me that with medicine being so competitive anymore, that the type of people who would be compassionate and caring sort of get washed out of the system. Is that a fair assessment or unfair? And how does the system sort of compensate for that?
Well, I'm going to summarize the comment, then I'm going to ask for some questions from some comments from the audience. I think you said at least two things, Jamie. I think you suggested that maybe compassion and care can't be taught, or you said, well, at least how can they be taught? And then you said, well, we've got a problem anyway in that the people coming into medicine aren't compassionate and caring in the first place. So I'm not sure. I think those are two different issues. Or I guess you're maybe implying that therefore they can't be taught because they didn't have the proclivity in the first place. Is that a fair summary of what you said?
Maybe it's missing the essence of what I'm saying. That there's something incompatible about compassion and caring with the very competitiveness of the system.
Okay, so you're saying that the way perhaps that medical students are selected, or is there something about the pre-medical process as well as the medical education process that sort of either pre-selects people against those qualities or burns that out of them once they get in? Or would you have that comment?
Well, maybe what I'm suggesting is that maybe rather than placing so much emphasis on teaching medical ethics to the students that are there, more emphasis would be on recruiting medical students that are more interested in the humanistic side of medicine, if that's possible. I don't know that it is. I'm certainly not claiming to have a recipe for how it might be done.
Actually, I think what I would say is that I think most people probably have an element of these characteristics in them someplace. It may be more deeply buried in some than others, but I think most people have some of these basic things, but they have to be developed. And I think maybe what happens in or should or could happen in medical school or nursing school or anything else, that if these things are modeled, I don't think you can teach them or create them, but by modeling them, you can help to develop them. And perhaps sometimes they're teachers are chosen for other reasons.
But it's the rewards in society, and primarily what I have in mind as far as rewards are economic rewards. Somehow go counter, like against the people who really sincerely are committed to those virtues. Then it seems to me that it doesn't matter who you have in the medical school as the model. I don't think Ivan Illich would have been influenced by his example or her example.
Other comments from the audience about that? Okay.
Jamie, I sort of, as a simplistic non-philosopher, have always tended to agree with Larry Colbert in his statement that if you don't got this by the time you get to be a grown-up, if it's not moving someplace, it's not going to come. And my tendency is always, these kinds of more, I'm speaking about moral reasoning, but I really think this is that concept, that it's there. And what we might do in medical education is beat it to death, put it underground, keep it down to where it's a great disservice. But I don't think we can go to by the time we get somebody, and this is my opinion, somebody at the age of 23 who has not this in his character or her character. We're not going to do that. I mean, that's, I feel there's
Jamie, I think I'm going to take a completely different approach. In my experience, people have compassion and care and caring when they enter medical school, by and large. I think it is selected for, maybe not as directly as you might like, but I think it really is actually consciously selected for, at least these days. My experience of medical training, however, is that it victimizes the student to a very direct and sort of vicious degree in so many, many ways, and it forces one, or how can I say this, seems to constrain one, all but the saints among us, to objectify the patients. They become, at some point in one's career, the object of one's pain. They are doing it to me. And the system, all of us, the society, ourselves as non-medical people, allow the system to be in which we really are put today in practice beyond training at some odds with patients. And there are barriers and obstacles built in at this point, bureaucratically and cognitively. I could elaborate on that as far as the models that people use, the way they present their requests to you for care is often not direct and often frankly dishonest, sometimes because they're not virtuous, sometimes because the system really won't support them being direct and honest. And so I think that compassion and care is down there. I don't think it's reinforced very often. I hope that it's possible to reclaim. But at this point, certainly in the system that I'm familiar with, the American system, one has to consciously go against the flow, I think, to be in touch with those characteristics.
So what you're saying is that the students coming in there have this compassion and caring. By the time they come out, something happens so that they're less caring. So rather than nurturing that in them, if anything, it's done in reverse.
Absolutely. Oh, no question about it. In the traditional system, the first 2 years you intellectualize the experience. That's your preclinical, scientific, basic science years. And the third year, you're absolutely victimized by the experience, brutalized by the experience.
Where'd you go to medical school?
And then the fourth year, you can reclaim a little bit of perspective, I think, and then you become an intern. And it's worse than ever. So yeah, I think it really beats it out of you.
There's plenty of. There's at least a moderate amount of medical anthropological data, or data on medical students and postgraduate trainees' experiences that do document that in general. Probably some of the newer family practice programs and some of the newer general internal medicine programs, and I would guess some of the newer programs have gone a long way, probably to eliminate a lot of the sort of the brutalization, but there's a lot of it there. In terms of the acquisition of characteristics, there's a moderate amount of data that there's a lot of value shifting that goes on among medical students and physicians in their early training. And so, although I don't think you can make any sort of a case that you can make a villain into a virtuous person, you can certainly make a case that you're in a position to enhance at least the good tendencies that they might have in probably a very significant way, because the system can do very well at burning them out. And likewise, it seems to me, and there are other people here more qualified to speak to this than I, you could just as well as enhance them as you could drill them out of people. And as far as the teaching of values and virtues, I suspect there's a fair bit of this in the educational literature, but I'm not familiar with it. I haven't seen anything on the teaching of virtues per se. People talk about the typical thing is the paradigmatic person like Jesus or Gandhi or Buddha and so forth, somebody of that level, first of all, who clearly have influenced millions and millions of people. No question. So biographical figures of a variety of sorts. In a more contemporary-based time, people like Winston Churchill. Most prominent American physician is probably William Osler, who was a turn-of-the-century person at Johns Hopkins. And I think these people have had a lot of influence on people. And then if you can develop strong faculty role models, I think they can have profound influences on students, and I think, in fact, they do. They're not all positive. Some of them are negative. And a lot of people are not very strong role models, and I think there's some fairly good data that most adults have had very few really strong role models with whom they've associated in their lives. Other people that know more about this might want to comment on it. So there is at least the opportunity, it seems to me, to develop stronger role models among physician faculty, but it wouldn't be easy.
Go ahead.
Well, I want to touch on that, ask you about the role models, because I think, in fact, what part of this is all about is the failure of the model. There's the other element of the public has placed the physician, the nurse, the angel in white, the savior of the health as this model, and in a sense we're saying that they're not living up to the model. And I'm wondering what your feeling is of the participation of the patient, the public, in the persona that they put on the medical field to fulfill, to live up to models, to changing models, and to how the public participates in this whole process, really.
Now, one of the first things I talked about earlier was the notion of excellence being different from perfectionism. And, a person can be an excellent practitioner and be benevolent and conscientious and have equanimity and perseverance, but it's really hard to have any of those things and be perfect. And I don't know how it is in the kind of jobs that you all do, but we all do things not right sometimes. We get a traffic ticket, or the mailman brings something to the wrong house, or the teacher doesn't have their facts straight and the students tell them they're stupid or something else.
where I work, nurses don't make mistakes. They commit medication errors. And I mean, that's, people do make mistakes, and granted, they can have bad consequences. They usually don't, but they're treated, it's hard to be calm and tranquil. It's hard to be honest. It's hard to be compassionate and caring when you're striving for this perfection. And I think the public doesn't always grant it to us. And I don't know if that's an answer to your question, but that's how I feel about it sometimes.
That really tied in with what I was going to say, which is I think that the health care professionals have been victimized by the public because of our expectations. Those of us who are a little bit older remember medicine, say, before the Second World War, when there were a lot of things that doctors simply couldn't do. I mean, there were just a lot of things that hadn't happened yet, and really all we expected of the doctor was that he'd come in and do the best he or she could, the nurse the best he or she could. Then as they could do more things, the expectations rose. And so now I think that the whole lawsuit business, the whole malpractice business is, not the whole thing, obviously there's some really bad things that are done, but in general it's the expectation that we have that a doctor is going to make us well no matter what we have, and that we're going to live forever. And then when he or she doesn't, we sue them. That is a victimization that I think makes it hard for doctors to do some of these things and puts up a wall between the doctor and the patient.
I think one of the interesting things in contrast is that why we're losing nurses in nursing. Nurses are leaving because of their perceived inability to provide compassion and care, because of the constraints and in the workplace and the demands put upon them by the technological needs that are there. And so somehow or another they're coming out of an education program knowing that they are the compassions and the caring, that that's the focus of their role. And the actuality and reality in the workplace is that they do not have the arena for this to happen. And the frustration is that they choose to get out.
Yeah, we had a meeting this afternoon about blood transfusion records, which is our bane right now and here. And a perfect example of this is we have these forms that we have to fill out every time you give anybody a blood transfusion, and there's 738 spaces you have to fill in on each form. And when they aren't filled in correctly, we have to, or completely, we have to go back to that nurse and make them go back to the original chart and do it. And we've had a big campaign the last 3 or 4 months to reorient people how to do this and how to do it correctly and to have them perfect each time. And I was sort of unhappy a couple of days ago when I got some incomplete ones back from someone who I'd just been through this process with, and I was kind of disappointed that he hadn't picked up on this and gotten it right, And so I took him to him and asked him to correct him. Well, he was so angry and upset that he just about walked through the door. That particular shift, he had given 24 units of blood to one patient and forgot 2 signatures out of all these things. And no one cares. I mean, it's not 100% and it's not perfect. So it's not good enough. And it's real hard to keep persevering sometimes in the face of that kind of thing.
And all the care that went with those 24 units of blood was probably as best it could be. The patient got excellent care, was monitored well, but because that was being done, 2 signatures got forgotten. And then only for the recognition he got
For that, for what he did that day.
I do think that's part of the problem with nursing care too, is that the nurses have to give some administration with each patient. They have to do so much record keeping, they have to do so much math, they have to do so much detail, as well as touch and hold and help the patient, that I think that a lot of times the amount of hours and the amount of work that's required of them are sometimes conflicting. We're not the best for giving affirmations or warm fuzzies on the kinds of care that's on. I don't know about what doctors, I don't know what doctors do for support and affirmation. I know as nurses, we can't do enough.
What do doctors do for support and affirmation? That's a really good question. Not nearly as much as they should. Maybe a small fraction of what they should. In fact, often very little at all. The idea is you're just supposed to do what you got to do and not complain. And that leads to lots of troubles, in my view. It leads to a circumstance where you can't share your pain, your problems, your hurting, and then therefore it's harder to build constructive means of dealing with it. There's certainly plenty of pain and discomfort and problems and frustrations. One of the differences in general, between nursing and doctoring is that most physicians don't have somebody looking behind them every second. They don't have any form. They may have their forms, but they don't have the kind of forms that nurses do, and rarely do they have them very closely looked at. The level of inspection is probably a factor of 10 to 1, if not 100 to 1. And so there are lots of differences. That sort of gets us maybe to talking about physician-nurse relationships, which I was hoping maybe we could talk about a little bit. In some ways, it seems to me like medicine and nursing are like two ships in the night that communicate by hand signals and semaphore, whatever you call those things, and but each sort of has their own leadership and their own drills and their own ways of getting things done, and they cooperate, but they're really not in the same ship, and it's sort of actually one's the Army and one's the Navy. Sorry for the military metaphors, which is not a good choice actually. Physicians don't know much about nursing. I'll tell you that right off. That's a problem.
I've seen some nurses do is some good education of doctors.
Sometimes, I don't know if there are some doctors that don't keep up with their studies, but I've seen nurses say to doctors that medicine isn't used anymore, doctors, that the side effects have been real serious with that. Would you relook at that and order such and such a medicine, or have you studied, or would you look at it? I've seen nurses do some good teachable moments with doctors that way. And some doctors profit from it, or maybe they hear it on a good day.
It struck me when you were saying the nursing and physicians are like two ships passing in the night. I've been to some hospitals where there's nursing progress notes and physician progress notes, and either reads either one. And it's exactly two ships passing in the night. Yeah, very.
It's interesting to comment about that's almost universal. And I'll give you my perspective on some of the reasons that is. Let's hear some of Karen. The things that each are involved in recording, especially in sort of technical services, to some degree, the things that each is concerned with recording are different. And from most, if you were to ask a typical physician about why they don't read the nursing notes, they would say something like this. I have to read paragraphs and paragraphs and paragraphs to find out about ordinary things of care that don't really influence the kind of decisions that I have to make about what to do. Secondly, I can't really digest out of those notes a good sense of how the patient is. I don't have the time to sit down and read the 3,000 words that occurred from the day before. So all those stuff, but then you might add that they never had any training in reading or thinking about them. And now, but some services like mental health and probably chemical dependency have doctors' and nurses' notes combined, which, and some institutions have done that. What's your perspective?
Yeah, that's true. In more progressive places, they're more collaborative. We're looking at doing something about having a patient care plan rather than a nursing care plan where all the different disciplines work off the same data bank. Part of our problem is that we have, these people's history of physical here, the occupational therapist and the physical therapist and the nursing, we're all asking for a lot of the same information. We all have it recorded in 16 different places because we've all been very turf, and we've all had a part of the patient. And I think we'd probably save a lot of frustration on the patient's part by having those questions asked only one time by one person and everybody reading the same data. Some of that is because our reimbursement systems in this country have encouraged that sort of separate record keeping so that each hospital, each part of the hospital could get paid for what it did. Now we're going to a flat fee for a total service, and it doesn't matter what each department said it did because you're only going to get paid, $5,000 anyway. And that's part of what's helping us to begin to consolidate again. But we spend a lot of time and energy in getting spread out, and I think it's easier to spread out than it is to consolidate. It's hard work.
Another reason that doctors don't read most of the other notes is they haven't felt they were very important. They have felt that their job was to decide what ought to be done and the other people were supposed to do it. And so why should you read all that? Because you sort of assume people will let you know if things aren't going well. And I don't personally agree with that view, but in general, that's the way people are brought up. And that's the way they're socialized in the system. And so we're in a period of transition to more collaborative type of patient care. It's just going to take a few decades to get there.
A real good example of that is I've spent an awful lot of time in the intensive care unit, and we have these huge sheets with two sides that we chart on. As long as I've been here, which is a long time, the only physicians I have seen that I know that consistently go and read the nurses' notes are the neurosurgeons who want to know the patient's mental status. And because what they have done or are treating is often diagnosed or the progress noted by how the patient reacts and what they say. And those are the only people that consistently read those notes, which I think is pretty telling.
I wonder if you would agree that there's a general problem just in the, sort of the circumstances and structure in which you work, namely that you're just trying to, each and every physician, each and every nurse is just trying to care for too many people. I think that's certainly a problem in my profession of teaching, that there's no doubt that the smaller classes, the more time you can spend with each student, the quality of education just goes up exponentially. And when, for reasons of economic stringency or whatever, you're forced into larger and larger classes, less and less time to spend with each student, then the job you're doing just isn't as good anymore. And I wonder if a lot of the frustration and a lot of the faults in healthcare aren't caused by that simple factor, that there just aren't enough physicians in proportion to patients. And similarly with the nurses, that everybody's just stretched too thin and you don't feel like you have the time. You just can't afford to spend the time necessary.
Well, I don't think there's a nurse in the hospital here that would disagree with that. One of the things that we've been looking at is in this grant I was telling you about is exactly what is the work of nursing. For a long time, nurses have done everything from dump the garbage to change the beds, to bathe the patients, to give them their medications and everything else and all. Sometimes all of that isn't required to be done by a registered nurse at that salary. So there is that, that perhaps we're trying to do too much and be too many things to everybody.
Because this had a great kind of effect on, on the spirit with which one enters into the work.
Right.
You're constantly frustrated by this.
Well, and I think another side of that that's very telling is that the economic rewards that are given in medicine and nursing are for the technologies, the procedures that you can document, not the time that you spend helping the patient get through that procedure or explaining or whatever. That's not where the rewards are, because that's not what our society has valued. I think one of the big reasons that we're looking at a change in the healthcare system now is that we have tried the high tech and found it wanting. It's not giving us what we need, and I don't think it's gotten bad enough yet that it's going to change anytime really soon. Although I think change is coming, but I think that discontent with just technology is forcing some change.
Are you saying then that too much reliance on technology has perhaps led to the frenzy of overscheduled time?
Well, I'm saying what's paid for is the technology. That's what society pays. That's what insurance pays for. That's what they pay for what you do to patients, not how you do it.